two subjects in one talk. Um, and the low dose induction, you guys have probably heard this before and probably know a lot about it. Probably a lot of it won't be new. Um, on the other hand, the long-acting injectables, um, there's some new stuff. The landscape has changed significantly regarding Sublocade and Brixadi. Um, and I'm going to get you guys all updated. So we'll start off with low dose inductions. And let's see, how do I? Uh,
Hey Todd, will you make that full screen for us?
yeah.
And then you should just be able to kind of scroll down to your next slides.
And the full screen is all right there. Okay. Oh, I can scroll down. Oh, there we go. Okay. So learning objectives for low dose inductions is be familiar with the different regimens. There's a lot out there. None of them are really standardized. And there's a whole bunch of them out there, and they seem to work. Although I will say that there are folks that say that low dose inductions are not that effective, um, and including Nina, who says erase the bottom. They haven't had a lot of successful low dose inductions. And then I've heard folks that at least one pretty bright guy at ASAM say the same thing. But um, you know, a lot of people use them, and they definitely have advantages. And it's good to know about it. And I've done it successfully. A lot of it depends on the patient because it can get kind of complicated, the regimens. So you want patients who can follow instructions well. Um, so we're going to talk about the advantages and the disadvantages, and then we'll talk a little bit about fentanyl because fentanyl has really changed the landscape quite a bit on everything. Um, so buprenorphine is a partial agonist, and it has a very high affinity for the mu receptor, meaning that if there's other stuff around, it's going to kick it off the mu receptor and take over. And that's a key principle when talking about low dose inductions, and you'll see why in a second. Um, so, um, one of the problems with inducing people with buprenorphine is that it's a partial agonist. So if people have a full agonist on board, like methadone, um, and it's still in their system, and you give them buprenorphine, it knocks that full mu agonist off. But now you're talking about a partial agonist, so it can put them in precipitated withdrawal, which is which is a significant concern when converting people. Um, some risk factors for precipitated withdrawal are obviously a high dose, short time to conversion, and then for some reason female gender. Um, and it can take as much as 96 hours um, to off methadone to get to a point where you don't really have to worry about this. And I will say that you know if we do our inductions at Full Circle. We do them all inpatient. I mean, yeah, we do them in person because we're trying to teach residents and have them see the process. But if I was out in private practice, I would do most of my bupe inductions outpatient. However, I wouldn't do it with methadone. The few patients that I have put in precipitated withdrawal, they're all on methadone. And the problem is that I like people to be off methadone for 48, 72 hours, more like 72 hours. And people come in and they say they've been off it, but they really haven't been off it that long. And then you give them bupe and it puts them in precipitated withdrawal and they're quite uncomfortable. And the most common treatment for precipitated withdrawal is giving them more bupe. And it's a little tough to convince someone who's feeling really crappy because you just gave them a drug that, hey, I'm going to give you more of this drug, and it's actually going to make you feel better. It's hard to convince them of that, but that's often what we do. Um, so what are we doing with low dose inductions? What we're doing is we're starting off with very, very low dose of buprenorphine, and then we're gradually over 5 to 7 days, sometimes a lot shorter, we're taking over the mu receptor. We're knocking off that full agonist little by little, so that at the end, all those mu receptors are pretty much occupied by buprenorphine, and the full mu agonist is just kind of floating around, doing nothing. Um, the the problem with the traditional way of doing inductions is that people come in and we need them in withdrawal. Because if they're not in withdrawal, that means they still have that full mu agonist in their system, and then we're giving them bup, and we're going to put them in withdrawal. So they need to go through some withdrawal. When they show up in the clinic, you know, um, they're going to be in withdrawal, like with a CAL score of like eight or over eight. Um, and Also, if someone is on full mu agonist for pain, and then we're asking them to stop their meds for 12 to 24 hours, or in the case of methadone, much longer, then they're going to have experience where they're going to be feeling pain. So with this method, they don't go through withdrawal, and they don't have a period where they're off their opioids and they're having pain. Um, the other advantage is that typically when we are converting someone from methadone to bup, um, we want them to taper their methadone dose down to 30 or 40, preferably 30. Now, methadone down to 30 is really not therapeutic as far as preventing cravings, preventing opioid use. So they're really not being treated adequately at that dose. And with low dose induction, you can do that at much higher levels of methadone. And just to give you an idea, the kind of dose of methadone we're seeing. So Brenda Hoyt can chime in on this. I mean, I was told, several years ago, the average methadone dose that raised the bottom was 120 milligrams a day. That's a lot of methadone. Is that pretty much the case, Brenda, would you say, or somewhere in that ballpark?
Not anymore. And with fentanyl, we're seeing much higher doses
I see.
being
Yeah.
required for reaching stability. Um,
Yeah.
so it,
That that
I
that
would
makes
say we're probably closer to the 150 mark.
Wow.
Then we've got some outliers, some that are a little higher.
Yeah, that's wild.
Hmm.
I mean, if any of us took 120 of methadone, we'd probably be dead, right? I mean,
Right.
we would be dead. There's no
Hmm.
question about it. We'd be dead. Um, so this is what happens. You know, let's see. I think the little blue guys are the buprenorphine, and then the brown guys are the full mu agonists. So you can see over time, um, the blue guys kind of take over, and then on day four, it's only blue guys on the receptors, um, and the full mu agonist is off the receptor, and that's the principle here. You're gradually replacing the full mu agonist off the receptor. Um, so um, I've already said some of this already. Um, and this is stuff you guys know pretty well. You know, we have people that when they come in for the typical induction, again, they're off their methadone or off their full mu agonist for 12 to 24 hours, and much longer with methadone. And we give them, usually 4 milligrams of bup. Or with methadone, I used to give them two because, I'd worry more about precipitated withdrawal. Um, Now, this might seem like a really low dose of buprenorphine. However, with low dose induction, we're talking about much lower doses. We're talking about like we give them zero point 0.5 on the first day, so much lower dose. And Again, whoops, this works best for low doses of methadone, not so much higher, and that's where the low dose induction can be beneficial because we can use it with higher doses of methadone, and we have those now. We've always had them, but now we have them really high, like 150. That's wild. Um, so how did anybody even come up with this idea in the first place? Well, um, they found that in some cases, when they'd use buprenorphine in the first 24 hours, when people were really not so much off their full mu agonist, um, there's a trend for more successful transfer, which is a little bit counterintuitive, but that's kind of what they found. And they thought, well, maybe we should take advantage of that. Maybe leave them on the full mu agonist and use really low doses and then titrate them up and try that regimen. So um, that's what we're doing, and I'm going to show you a lot of different regimens. I'll show you the one that I use, but um, it's again, none of them are standardized. Um, I don't know how I don't know how well studied they are, and none of them are really wrong. I mean, you have to decide. You can do this over even a day, which is very unusual, but you can do it over 3 days, or you can do it over a month. So what we're finding now is with these really high doses of methadone, um, people are taking longer to do this. I mean, the typical time was like 7 days, 5 to 7 days. But now, these really high doses, you can stretch that out. I mean, we usually titrate the buprenorphine dose up each day. We're doing this. And at the same time, we're leaving them on the same dose of the film agonist. Um, and it's you can give it like a couple of days in a row where you're giving them the same bupe dose, and you're not increasing it that each day like we just talked about. Um, and so buprenorphine actually there's some neuromodulation that goes on with the receptor, and it allows for recovery from tolerance. So there's stuff going on a cellular level where they regain some of their sensitivity to the opioids, and that tolerance starts to go away, um, and that's one of the benefits of buprenorphine. So this is one technique, where you're using like zero point 0.5 for the first day, 0.5 BID second day, 1 milligram BID for the third day. I mean, you can read this. And then on day 7, you're up to 8 BID, you're up to 16, and then you stop the film agonist. You might do this on day 6 after 12. And like I was saying, you can pause for a day or two. Withdrawal symptoms occur, or things just aren't going as smoothly as you want. You can pause it. Um, so, this is obviously a complicated regimen. And this is where blister packs or pill packs can be beneficial for patients. And then you might ask, oh God, how do you get 0.5? Well, that means like taking a quart of a 2 milligram pill. Um, and if someone's in the hospital and you ask the hospital pharmacist to do this, they might say, I'm not doing that. I can't really precisely cut a 2 milligram pill in quarters. And that's where the patch can help. So if you look at the transdermal buprenorphine, the highest dose is 20 micrograms per hour. And if you do the math times 24, that's 0.5 for the day. So you can start them off on a patch, and I'll show you some regimens where we're using the patch. Now, it's, I always thought it was like illegal to use the patch for someone with opioid use disorder. It's really indicated, it's FDA indicated for treating pain. Using it for opioid use disorder is it's an off-label use. And I always thought we could get in trouble with the DEA for that, but that's not really the case. I talked to, is Elaine on this call? Elaine from Medicaid?
Yeah, I'm here.
Oh yeah. So Elaine was just telling me, and actually I looked it up too. That it's not, it's off-label. It's not illegal. You're not going to get in trouble with the DEA. People do it all the time. So you don't really need to worry about it so much. I don't know if you want to add anything to that, Elaine.
No, just what we had discussed is that there's a greater likelihood of legal and regulatory issues if you were to use Butrans or Belbuca long-term for treating OUD, which you would not do.
Yeah.
And that's really where that legality regulatory issue stems from. And that, in common practice, you can use off-label, you can write for off-label use all the time. Insurance plans may not cover it because
different story with insurance. Yeah. I was listening to an ASAM lecture last year, and the lecturer is from Canada, and they don't have the same regulations up there, and they have some wild regimens. I mean, this guy was talking about using 6 patches initially, 6 of the 20 microgram patch, and then after 12 to 24 hours they put another 6 on. So these people are walking around with 12 transdermal patches on. I mean, that is so expensive. They're really expensive. And we don't have any commercial pharmacists here that can tell us the price, but maybe Elaine knows. I mean, they're very expensive.
Like $1,000 a box.
Oh my gosh! Wow. So here's let's see, slightly different but similar. Again, same principle. You want them on a predictable dose of their full agonist before you start doing this. So if you have someone like that's just had surgery, they're in acute pain, and the dose is being varied, that's not a good time to do this. You want them on a very stable dose, predictable dose. And then, if there's withdrawal, don't forget about the adjunctive meds, clonidine, ibuprofen, loperamide, antiemetics, and others. And then, like I said, you can pause the induction. This is the same sort of thing, same principle. Um, Again, there's so many different regimens. And when I was listening to one of the ACM lectures recently, and someone asked, is there a regimen that's like the best, or that like everybody should use? And the lecturer said, no, but that's the beauty. It gives people flexibility, and um, so no, there's no like definite regimen, but there are shorter regimens like this one. This is a 3-day regimen, and um, this is good. You want to get someone out of the hospital, and you want them on their bupe before they leave. This is something you can do. And in a minute, I'm going to talk about fentanyl. Um, anyway, and this is over 20. I've never seen anybody do this, but I really haven't heard about people doing it. But you can do a 24-hour one as well. But again, never seen it done. The Yeah, we talk. This is going again talking about the patch. I think I've already said this. Um, and this just gives you an idea of, what the sublingual equivalent is from the patch and the buccal films, and then intravenous, and then the transdermal patches. So this is just for your reference. And here's a transdermal regimen. You put the transdermal patch on the first day, and you can sometimes you can even put 2 pouches on. Then you can move to your sublingual buprenorphine, and you could probably do the same with buccal as well. This is another fast regimen using the patch. You guys can come back to this later if you want to try this. Oh my gosh, I'm sorry that this copied like this. Anyway, this is using the buccal formulation. Same sort of principle, 150 micrograms every 6 hours on day 1. It's and then you move to the sublingual. Here's something I just learned about. This is it's another way of giving microdoses, and this is where you dissolve a film, 8 milligram film of bupe in a little bottle of water, and then you use a dropper, and it'll have when they go through the whole dropper in a day, that's 8 milligrams. So, not something I've done or seen done, but I just learned about this at the ASAM conference, and this is another kind of novel way to deliver small amounts of buprenorphine. So fentanyl, fentanyl's changed the entire landscape, as Brenda was just saying. It's people have such higher tolerances now because fentanyl is so potent, and it's really changed things in what we have to do. So, fentanyl, first of all, is very lipophilic, and it seeps into especially with longer use, it seeps into the fatty tissues in the body and then can seep out. But it also gets into the fatty layers around the neurons. So it's complicated, and we've had 2 lectures on fentanyl, use of buprenorphine with fentanyl from I'm blanking on his name. What's his name, Shannon?
Dr. Cloberdon's.
Dr. Clover, yeah. So, like, what do you do when someone's using illicit fentanyl on the street, right? This is someone, I mean, we don't want them to, we want, again, for low induction, they need to continue to use their full mu agonist while we're using the partial agonist, while we're using the buprenorphine. We're not crazy about them continuing to use fentanyl from the street, right? I mean, we don't know what they're getting. They don't know what they're getting in a lot of cases. But sometimes you have to do that. Sometimes, you have to say, I mean, I wouldn't put in your notes you're recommending that. I put in your notes that you've suggested every other option. And they're not amenable to other options, and other options aren't going to work. And then you might say, all right, well, if you're going to do that, you need to take the exact same dose of fentanyl, and we're going to do the buprenorphine. And then you want to do as quickly as possible, like 3 days, right? Or even less. because you want to get them off the street fentanyl. Um, the other thing you could do is put them on a full mu agonist. Now, um, if they're having pain, then you can treat their pain with a full mu agonist. Um, but this is risky stuff. And Dr. Hayden, who's on this call, didn't think this was very wise to do because he thought would be dangerous, if they mix with fentanyl. And I think he has a really good point. So this would have to be like a really reliable patient. Um, and it's risky. The other thing you can do is let me just go ahead a little bit here. You can dispense, not prescribe, but you can solicit the DEA for 3 days of the full mu agonist, usually methadone, and put them on that while you're doing your buprenorphine induction. Now, this can only be done by a hospital-based pharmacy. So this is like done, in the ER, or it's done, maybe with discharge. This isn't really something that's very practical, for outpatient. And maybe you could pull it off, get an outpatient pharmacy to dispense the meds. I mean, an inpatient pharmacy. But will inpatient pharmacies even dispense meds to someone who's an outpatient? I don't know. We can ask, uh, where'd she go? We have a hospital pharmacist here. Lucy. Lucy, what do you say about that?
Yes, I think it might depend on the institution, but I think the broad answer to your question is yes, they can. A hospital pharmacy can dispense it, and because they're it's the same 3-day rule that applies to them as well.
Okay, good to know. Thank you. Glad
Mhm.
we have you here to answer that question. So let's see what I left anything out here. Yeah. If someone's going to be using fentanyl at home when you're doing this induction, you want all these people to have Narcan, but especially these guys. There's also the never use alone line. They can call the hotline while they're using, although the Trump administration has just eliminated all funding to this program. Really unfortunate. Um, it's still in existence for now, but it may go away. And But we'll see what happens with that. But that's not a bad thing for people to do, to be talking to someone while they're using their film agonist, and who's someone that can call EMS if things start going south. Um, so um, let's see. Yeah, we talked about this already. 3 days. Okay. So this is just one example from someone talking at ASAM. Now, when it says dispense 15, I think they're talking about 10 milligram pills, so 5 a day, right? And the dosage you're going to use, like 30 to 40 to 50, sometimes 60 if they're using a ton of, if they're using a lot of fentanyl, you might need 60. And then in the meantime, you're doing the low dose bupe, as you can see on the bottom there. So some tips to succeed in this, first of all, you've got to have a fairly reliable patient. The bubble packs can really help a lot. Dosing guides, and then good communication. If someone, and it's good that we have Brenda here, because if someone's coming to you from a methadone clinic and they're asking you to do this, well, you want to have good communication with Raise the Bottom or any other methadone clinic, so you guys are working together, because there has to be some collaboration here, right? They need to know you're doing this. You need to know what they're doing with the methadone. So, talk to them. Do you want to add anything to that, Brenda?
No, we very much appreciate communication. If usually the patients are pretty good about letting us know that they're going to be starting a low dose induction somewhere else. But and if we haven't heard from the prescriber that's going to be doing it, we do try to reach out because we want to make collateral contact, coordinate care, make sure we're all on the same page with the plan.
Sounds good. So a conclusion, pros and cons: can avoid significant withdrawal, can avoid significant pain. It might be more acceptable to patients who have gone through precipitated withdrawal in the past some of them are really afraid of it happening again. So you can say, hey, we can do this in a way that you're not going to have precipitated withdrawal. It works better for synthetic opioids, like fentanyl with unpredictable clearance. Although high dose induction for people using fentanyl is becoming more and more common, especially in emergency rooms. I mean, you hear a lot of these lectures at ASAM, them giving, high dose bup. And I think Andy talked about that. But again, these are ER docs, right? So the people are in the ER and they're monitored. And so how well this is going to work for outpatients is, I think, a little bit up in the air. And yeah, it can take longer than your typical induction for sure. So before moving on to the next topic, we've got some really bright people on here, like Dr. Hayden and Lucy and Brenda, people that are prescribers. I have another lengthy lecture coming up, but I wanted to leave just a couple of minutes for any other input or just anything you guys want to add. Happy to hear it if we could limit it to just a couple of minutes. Anybody? Or Elaine? Elaine is incredibly knowledgeable about these things. Okay, well, that being said, I'm going to move on to, here's a shared decision-making tool you guys can have for reference. And here's the never use alone line, which is probably going to be going away, unfortunately, because their funding has been removed. Okay, we missed our title slide, but the title slide here is long-acting injectable buprenorphine, meaning Sublocade or Brixadi. I think there's a lot of good stuff in this lecture, stuff that some of you might not know. I don't know, you probably do, but you might not. So why do you want to use long-acting buprenorphine? Well, better adherence, right? They don't have to remember taking their meds every day. Better attention and care. There has been better attention and care. Better attention, I think, than sublingual. Better opioid abstinence. And this is all compared to sublingual. So there are different advantages of this compared to sublingual. More consistent buprenorphine levels and generally higher bup levels. And this is significant. And I'm going to show you guys some graphs of bup levels in just a couple of minutes, and you'll see that they are generally higher than using sublingual buprenorphine. Helps with patient autonomy because people have choices. And as you'll see later in this talk, this can be used as a mechanism to taper people off of buprenorphine. And you're going to have a lot of patients that come into you and ask about this. They say, hey, I've been reading that this injectable buprenorphine can help me get off buprenorphine. And that is a very valid comment and something that you guys can do. And we're going to talk about that later in the lecture. It prevents diversion. Obviously there's no lost meds. There's harm reduction in the setting of continued use and inconsistent use of sublingual bup. If someone doesn't have a place to keep their meds safely, like if they're homeless, well, this will solve that. And then dental issues. And I don't know why this is questionable. To me, it makes, it's common sense. I mean, sublingual bup can cause dental issues. That's why we need to, when someone gets bup, you have to wait before they brush their teeth. How long is that, Derek? Is that an hour? That they wait before they brush their teeth after they use sublingual bup?
I can't remember off the top of my head.
Does somebody know the answer to that?
I have heard that, Todd. I think it's an hour.
It's an hour. Okay.
Yeah, they rinse out really well, and then even after rinsing out, just waiting an additional hour just to be safe since it can be abrasive.
Yeah. Okay. And then this is a big one. Protection from opioid overdoses. The reason I put Derek on the spot there is I remember this being part of his lecture way back when. He gave a great lecture on bup in general, and I think he mentioned this, but that was a long time ago. And I don't remember. I didn't remember it either. So protection from opioid overdoses, and we're going to talk a lot about that. So now, what are the contraindications? Well, I mean, obviously, if they're hypersensitive to meds or components, then you don't want to use it. Liver disease. This is a moving target, right? When I first put together a soap for the residency, like, I don't know, 6 to 12 months ago, they said, don't do this with patients that have moderate to severe liver disease. There used to be significant concerns about using buprenorphine with liver disease, not so much anymore. And they don't really, I just read the handout from the drug company, and they didn't say, don't use it with moderate to severe, as they have, 6 months ago in their their prescription information for prescribers. But they do say get LFTs initially and then monthly LFTs. My own bias is that's overkill. I mean, getting initial LFTs, good idea, but checking them every month, um, I don't do that. I don't know if anyone does. Do you do that, Derek or Brenda, with Bupe in general?
No, I don't. I don't.
Yeah,
I
yeah.
don't.
If they have an upcoming major surgery, maybe you don't want to do this because a lot of surgeons they don't really know. They get a little freaked out if someone's on buprenorphine. They don't really know how to handle the foamy agonist. It's actually pretty easy. You can add the foamy agonist on top of the bupe to control their pain, but might not be a good idea if they're having major surgery. We know that's coming up because the surgeon might get a little freaked out. Hey, they've got buprenorphine in their body and we can't get rid of it. This can also be involved in the serotonin syndrome if they're on other serotonergic drugs. Usually it takes, from what I've learned, or what I've heard, I should say, usually it takes 3 serotonergic agents to really put you at significant risk. But I mean, I would not do this if they're on like sertraline. I don't know if Lucy has any comments about that or any other pharmacists that are on here.
Yeah, I would say it depends on the drug. For example, like an MAOI type of antidepressant, I'd be a little bit more concerned, whereas kind of the routine prescribing of things like SSRIs or even concomitant SSRIs and second generation antipsychotics with this, I don't think that would be that concerning to me.
Okay,
It'd be more
good.
about the drug class itself.
Okay, great. Thank you. And then, if they're on CYP3A4 inhibitors, just keep that in mind because inducers or inhibitors, it can cause over or underdosing. So, and this is a great thing because Medicaid is now paying for this. This is why this is such an important lecture, both for you guys and for the residents here, because we have so many Medicaid patients, and we're really grateful to the Medicaid people, Elaine and whoever's over there. I don't even know who the director is now, the medical director. Who is the medical director, Elaine?
There isn't one.
There isn't one. Okay, well, there you go.
Magni's position has not been backfilled.
Oh, well, obviously a huge loss, Maggie not being there, but the VA has her now. She's great, but Elaine is fantastic. And um, every time I've called Elaine with questions, she's known the answers to every one of them, and she's been incredibly helpful. So thanks, Elaine. Really appreciate that. But these are, so which ones to use? We're going to talk a lot more about this. And we're going to talk about how you administer Sublocade differently than Brixadi. We're going to get into all this in just a minute. So what's happening when you give these? Well, you inject them and they form these little polymers, these little balls, in the subcutaneous tissue, and then over time, they slowly release the medication from the balls, and that's why you get the sustained level of buprenorphine. These can actually be surgically removed. This is very, very, very rare. In fact, I read somewhere it's only been done twice, as far as they knew. The polymers formed by the Brixadi are more difficult to feel. I'm not sure they can be surgically removed. Probably a lot more difficult. Now, this has changed, right? This is where you can give both Brixadi and Sublocade, all these different sites, in the legs, in the buttocks, in the abdomen, in the triceps, and it used to be that you could just give Sublocade in the abdomen, but that's been changed. So now you can give them all over. I mean, on these sites. I will say something about triceps. Well, let me get to the next slide here. So, triceps are thought to be less painful, but I was reading in the Brixadi literature that there's 10% lower levels of the medication when they're done in the triceps. And I think they said don't do the triceps until they've had, they've reached a good steady state, so like until they've had 4 shots elsewhere. So I wanted to give you guys some tips on minimizing the pain. So in my experience, most people don't have significant pain, but some people do. Some people do have significant pain because, you're injecting this medication, it's actively forming these little balls, and I don't know, that causes pain. So it turns out that the warmer the medication is when you put it in, the less you're going to have pain. Now, it used to be that you had to refrigerate Sublocade you had to keep it refrigerated, but now you don't. You can leave it out of the refrigerator for 12 weeks. But if it is in the refrigerator, you need to take it out 15 minutes before you give it. And it also helps to put it under your arm. I heard one prescriber at ACM talk about this. He said, it really helps people. Put it under your arm, warm it up, and there's less pain. Brixadi doesn't need to be refrigerated, period. So not even a factor. You can ice the skin before you give an injection. You can actually inject lidocaine. They can use transdermal lidocaine at home, and then you can also inject a cc of lidocaine in the skin. You can use freezing spray. Brixadi generally causes less pain because it's less volume, smaller needle, and lower viscosity. And a couple of tips on giving the injection: get the air out. There's usually going to be air in the syringe. Get it out. Look at the medication. Make sure there's no particulates in it. It's kind of amber, but you should be able to see through it. Clean the skin. The whole thing here is you do not want to get this in subdermally, which is more superficial, or IM, which is deeper. You want to get this in the sub-Q tissue. And you do not want to get this in a vessel because it can actually kill someone. Because you get this in a vessel and it forms those little balls. And, you don't want balls floating around the vascular system. Bad thing. So you clean the tissue, you make sure there's no air, you make sure there's no particulate matter, you tent the skin, you go 45 degrees with the Sublocade, 90 degrees with the Brixadi. Why 45 degrees with Sublocade? Because the needle's longer, and that's what you have to do. So Brixadi is just 90 degrees. And then you always want to document where you're injecting because you want to rotate the injections. And when they come in the next time, if it's not, you want to make sure you're not going in the same site again. Skin problems are rare. Infection, necrosis, it can happen, but not if you go in the subcutaneous tissue. They're very unlikely to happen. And you got to remember, you got to aspirate before you inject, because again, you don't want to see any blood come out. You don't want to be in a vessel. And this is the other reason why never should a patient have this medication in their possession. We don't want people doing their own injections. I mean, we've had people at the residency give themselves naltrexone. They were supposed to pick it up and bring it back here, and we give the injection, and they've given it to themselves. We don't want that here because we don't want that with Vivitrol as well, but here it can be really dangerous. Here's another thing. You guys have probably noticed this yourself. The medication kind of leaks out of the hole when you inject it. So I don't know if this helps or not, but I think it does. And I heard someone else mention it. I'll take my finger and put it over the hole, and I try to keep it in after I do the injection so it's not leaking out. And then you could place an ice pack over the site for the pain. And then you don't want to push on the site after you injected it. Don't mess with the site because the pressure can flatten out the bowl and make the medication diffuse faster over time. And then you also want to tell the patients, hey, don't wear a tight belt or tight pants over this, because again, it's pressing on those polymers, those balls, and it's pushing it out, and we don't want that to happen. So yeah, I mean, you do the injection, and you want to put some pressure on there because there might be a little bleeding, but really don't. Just put a Band-Aid on it and go from there. Okay, let's talk about levels of medication. So there's two numbers here to keep in mind. You've got 5 nanograms and 2 nanograms and 5. So if you get over 2 nanograms, that greatly reduces the risk of an opioid overdose. Unless you've got like xylazine on board, then that doesn't help, right? Because it's not gonna block that because it's not an opioid. But I've also heard that with really high dose of fentanyl, like approaching a gram, you might need 5. But in general, 2 nanograms will greatly reduce the risk of an overdose. And then you've got 5 nanograms. 5 nanograms will, of course, also reduce the risk of an overdose, but also it eliminates the drug liking. So if they take a bunch of opioids, they're less likely to have the hedonistic, the hedonic experience, getting high. God, Mike, I don't know how I get rid of this. We're having a big meeting, and every time someone logs on, it beeps on my. Oh my God. We'll have to just deal with it. So if you get above 5, they're less likely to want to use because they're not having the pleasure, and they're less likely to have cravings. So that's the other number to keep in mind is 5. So 2 and 5. Okay, so now let's look at a few graphs here. So this is someone who got sort of the usual doses, right? You get 300 the first month, 300 the second, and then 100 after that. Now, what I want you to notice is this. See that right there? You give a dose, it goes up over the 2, but then quickly goes down less than 2. So what does that lead to? Well, that leads to the new way that people are doing this for the most part, which is after 1 week, you give another 300. You don't wait a month. You don't wait a month. You give another 300 after a week to get that level up over 2. And again, major kudos to Medicaid in that Medicaid will pay for that. So you prescribe another 300 a week later, you'd expect people to, payers to say, well, we're not doing that. We want to wait at least 26 days, which is what we've always done. But Medicaid will pay. I don't really know what the private insurers do. It probably depends on which one. I don't know if anybody has any information on that. But I know Medicaid will pay for it. And
Really
kudos.
quick, Todd, question on that. Does anybody know with Medicaid, is it still buy and bill?
No, it's covered under pharmacy.
Oh, it is now.
Yeah, you can still do it. You could still do buy and bill if you choose to,
Oh, we prefer.
but pharmacies can dispense it to your office
Okay.
administration.
And and just submitting Medicaid billing. Or
Well,
Medicaid
no,
billing.
the pharmacy would bill Medicaid, so
Oh,
you wouldn't
gotcha.
have to.
Oh, awesome. Perfect. Thank you
Okay.
so much.
Thanks, Lee.
Mhm.
All right. Now, this is, if you talk to there is some argument for using 300 every month. And I talked to the drug rep who just happened to stop by our clinic down Idaho Street, and he said, yeah, we go with we recommend 300 every month. Now, what's the advantage of that? Well, here's the advantage. You can do it for a while and you get up above the 5, which is, that's getting up where they're not going to have the liking anymore, the likening. So they're not, it'll help with cravings and help with use. And so yeah, this is what I was saying. Give the second dose a week later and it gets them over that 2. Bam, here's the blue line. So that's what I'm doing now, and that's what I think we should be doing to protect people from an overdose, keep them alive. Now, there's a lot on this slide, but there's a few things I want to point out. In fact, let me go to the next slide and just show you things I want to point out. So, if you look at the trough, well, this is divided. Look at look here first. We're talking about sublingual, and we're talking about Brixadi, and then we're talking about where's Sublocade on here? Shoot. Okay, let's go down here. Let's skip Brixadi for a minute. So we got transmucosal, which is sublingual, and then we have Sublocade. So this is the average, and as you can see, with sublingual, 8 and 12 are both below the 2, and that's the average level you're getting during the time during the 26 days. I mean, the 26 days only applies to Sublocade, but here's you have someone on everyday sublingual. Well, the average dose is less than 2, unless they're on 16. That's why 16 is kind of a sweet spot, because here they're 2.16, so that's above the 2, so you get better protection from opioid overdose. You're not getting quite the decreased liking like you get over 5, but then if you look at Sublocade, it's all over 2. In fact, even the trough, even the trough is over 2. I mean, the trough, even with 16 of buprenorphine sublingual, the trough is still, 1. So that's low. but Sublocade, you've got even the trough for 100 is over 2. So as you can see, there's definite advantages is in terms of level and what that might lead to in giving injectable Sublocade compared to sublingual. Let's go to Brixadi now. So Brixadi, if you're giving the 64, you get an average of 2, and then 24.96, you get an average of 2.9, and then the 32 weekly or the 128. These are divided into weekly and monthly being higher. But then if you look at the trough, these troughs are they're low. I mean, 16 is at 1.4, the monthly is at 2.0. So I'm not saying don't use Brixadi, but the levels are not as good as they are with Sublocade. I will say that, and I don't know if any pharmacists can comment, but I've heard Brixadi is cheaper to buy than Sublocade. So yeah, so I pretty much just said this. Yeah, I just went over all this. Okay. So, how much do you give depends a lot on, it's a lot of this depends on cravings and how much bupe they're using before, right? Again, the Sublocade drug Replitate, just give everybody 100, 300 a month. I guess that's the safest thing to do, but it might be a little overkill. So Up to Date says for long-term bupe users, if they're taking over 20, like 24, then you go 300, 300, and then 100. And then you continue 100 a month. If they're on like 8 to 18, 300 first month, and then 100 after that. If they've only been using bupe for a short amount of time, it doesn't matter how much they're on, give them 300 twice, and then go with 100. Now, if they're on fentanyl, which so many people are, often you're going to need 300 every month. And if they're on 100 and they're having continued cravings or use, then go up to 300. Now, I will say that the 300 and 100 are the exact same price, and there is wiggle room here because you can give them maybe 200. I mean, you can take the 300, squirt a third of it out into the sink, and give them 200. This is not really that cookbookish, and you can kind of vary things the way you need, as you need to. And then you can also supplement with sublingual buprenorphine, which we're going to get to in just a minute. And again, except for the first 2 doses of Sublocade, the minimal interval is generally 26 days. So this gives you the recommended doses for Brixadi, depending on how much sublingual bupe they were on. And you guys can read this and have this as a reference. And then the second table here is if you want to convert someone from weekly Brixadi to monthly. So if they're on 16, then you go to 64 a month. If they're on 12 to 16 a bupe, then 24 weekly or 96 monthly. So supplementing sublingual buprenorphine, this is actually pretty common. And you should not be afraid to do this. And when you give Sublocade, it takes like 12 to 24 hours. Where is it now? Sorry. To reach your peak level with that first dose. It goes up pretty quickly, but it's still 12 to 24 hours. So you may need some sublingual bupe, like up to 8 milligrams to get them where you want. And if you have someone with cravings, no matter what they're on, you might want to supplement. And you listen to people talk and they say this is so common. And like the Brixadi, like especially like weekly Brixadi, it's almost something they always have to do. You can think of it like nicotine replacement therapy. They're on long-acting patch, and then you supplement with other things. So this is a change. So what conditions do we need before giving long-acting bupe? So it used to be that someone had to be on 8 milligrams of sublingual buprenorphine for a week, every day for a week, before we could do Sublocade. That's no longer the case. The FDA is now saying that you can give a 4 milligram test dose, and then you watch them for an hour. If there's no significant withdrawal, then you proceed with 300. Same with Brixadi. 4 milligram test dose, no withdrawal after an hour. Give them 16, and then give them an additional 8 milligram dose in the first 3 days to get them to 24. And then you can give them additional 8 milligrams over the first week to get them to 32. But you have to wait 24 hours before giving them that additional 8. And how much you give them, for subsequent weekly doses really depends on what dose worked during that first week. That's the dose you want to use in Brixadi. So now, before I get into this last part, I will say that is the FDA recommended protocol. But you listen to the ASAM docs talk, or at least the ones giving this lecture, and they say, we're not that comfortable with this because 4 milligrams is kind of an odd dose. It's not 2. It's not. It's an odd dose. It's not low dose. It's not high dose. If they're on, and again, if they're on fentanyl, you may not be comfortable giving them 4 until maybe 36 hours. And the peak plasma concentrations, there's quite a range in when this happens, but it can happen in the first hour. So you might not even be seeing the maximum effect of that 4 milligram dose in the first hour. It's also hard to watch people for an hour, and there may be a higher risk for withdrawal with a pill preparations than injection. So this is this is not something I expect you guys to go out and start doing, but I just wanted to put this in here because they talked about this at ASAM and seemed to like it. They will just give a 7-day dose of they'll give the Brixadi weekly dose, which takes a while to get up to the pre-concentration, and it's kind of a smooth deal. And they say this works pretty well for them. I mean, I'm not going to do this yet. This is more kind of I don't know, maybe experimental is not the right word, but this is something that's just being done by some of the docs, and we'll see what happens down the road.
Hey, Todd, just FYI, we've only got about 2 minutes left.
2 minutes. Okay, darn. Okay, we got to get down to this. All right. So Brixadi, this is direct to inject, and I'm going to skip this slide. So obviously, if the cows are low, you're more likely of having precipitate withdrawal. So what do you do for injected direct? I would do the 4 milligram dose. If they have a cows greater than 8 and at least one objective sign of withdrawal, then you can probably just go ahead and give them the Brixadi. If they have a low cows, you might want to give it to them and say, hey, you might go through precipitated withdrawal, but then at least you're on the buprenorphine, and you just take it from there. But I think at this stage, since it's the FDA recs, I'd still probably go with the 4 milligram dose, but just be prepared. You might be precipitating withdrawal. I'm almost done. This just shows you how long injectable buprenorphine sticks around. Now, this is the typical 300, 100, and as you can see, at 2 months, you're still above the 2 nanogram level there. So, and then, getting way out here to, 52 weeks. Well, I'm sorry, how many weeks is this? 80, 32, that's about 50 weeks later. You've still got some buprenorphine. I mean, 12, a year after getting their last bup shot, they've got detectable levels. Here's the same thing after using 300. So this is definitely a viable way to taper people off of buprenorphine using the long-acting injectables. What about treating pain? Can you treat pain with long-acting injectable bup? Well, sure. I mean, there's not much in the literature, but hearing from other people's experience and just using your common sense and the fact that you generally have higher levels of sublingual, then this should be viable. And I wouldn't steer people away from it. You can supplement with sublingual buprenorphine if the pain isn't being well treated. This is the very last slide. Some logistical concerns. It has to be double locked. The injectable has to be like locked cabinet to locked room. Pharmacies have to be REM certified, not the clinics, but the pharmacies do. Like I said, out of refrigerator for 12 weeks. And the very last point is a real sticky point here at the residency. the DEA says that you can only administer this at the clinic that has the address that's on your DEA license. And if you do this at a different clinic, you get in trouble. I've actually talked to the DA about this. They have no logical reason for this. There's no logical reason. It's really stupid. So like some people here are telling me you can't give Sublocade down at our Idaho Street clinic because your DA license is up at Raymond. I say to that, you know what? I'm willing to take the risk. Hopefully, it won't be an institutional risk. And then when I was at ASAM, I was talking to folks from Chicago, and they say, we give this stuff out of vans all over the city. We don't worry about this. So I don't know. It's a stupid rule, and I'm not really going to worry about it, but just so you guys know about it. And that's all I got. I'd love to hear any comments or questions. Or sorry, sorry I went so long, but it's a lot of material.
Todd, thank you so much. We are a minute over. I'm just going to comment on a few things. You can go ahead and stop your share that were posted in the chat. Alice did post a couple of alternatives to never use a loan since that may be losing government funding. And then I'm just going to read what Derek said, and then we'll close out here. Derek said, regarding the flexible dosing of Sublocade, I think it's great to have options. However, there's no direct evidence that I've been able to find that shows that giving the second dose at 1 week improves outcomes, and it was approved based on pharmacokinetic modeling. I think it's a great option if patients are not controlled, but I'm not convinced that it should be the standard of care. So just a note on that one. And then
Let me just comment on that real fast. I think that's a very legitimate comment. And Derek is always very up on evidence, which I really admire. I think it is becoming standard of care, just being at ASAM. And we'll see what happens. But thanks for that input, Derek. I don't know what the right thing to do is. I'm probably going to give it a week later, just because everybody else is, and it does seem, but based on the pharmacokinetics, it does protect from overdose. I don't know if Lucy has any comments, or Elaine. I mean, I know Medicaid is paying for that, so they must believe in it too.
Things are changing very quickly all the time. So thank you. And Todd, lots of accolades. Great talk today. This was really, really awesome. I know we are 2 minutes over, so I will go ahead and close out. We are going to be back in 2 weeks on Thursday, February 26th from noon to 1 p.m. Mountain Time. We're going to have Lena Smith and Debbie Ruiz, who are with Tribune Life Services in Caldwell. They will be presenting about adolescent substance use treatment. So we hope to see you then. If you guys do have any questions specific to Todd's talk today, please feel free to reach out to me or put them in your survey, and I will send those questions to Todd and he can address them either directly with you or perhaps in our next session. So thanks, guys. Appreciate all of you. Have a great rest of your day.